and the 40th of this year. So, we are here to discuss the latest book by Anuradha Mascarenhas on our own Dr. Soumya Swaminathan. This is At the Wheel of Research. It's an exclusive biography of Dr. Soumya Swaminathan. To discuss the book, we have Dr. Nalini Krishnan. I have pleasure in introducing her. Dr. Nalini Krishnan is an MD in internal medicine who is specialized in tropical diseases and industrial medicine. She has more than 40 years of experience in designing health programs in community health and the workspace. Dr. Krishnan is one of the founding members of REACH, an organization working to build a multi-stakeholder approach in public health with a focus on ending TB tuberculosis by engaging communities. Dr. Krishnan is director in Kasturi and Sons Limited, the Hindu group, and during her tenure at the Hindu, she has set up and administered a comprehensive health center for preventive as well as treatment care for all employees and their families, instituted programs such as workplace health promotion, retirement planning, health and safety at work, prevention of alcohol and substance abuse. She has also spearheaded the development of company policies on health and safety, de addiction, and gender inclusiveness. It's our pleasure to welcome Dr. Nalini Krishnan. Please. About the author of the book, Anuradha. Anuradha is a senior editor at the Indian Express based in Pune. Anuradha writes on health, research developments in the field of science and environment and takes a keen interest in covering women's issues. With a career spanning over 25 years, she has won multiple awards, including the prestigious Press Council of India National Excellence Award in Journalism for Gender Issues, and was shortlisted for the Red Ink Award for Science and Innovation. She is a gold medalist in communication and journalism from the University of Pune and holds a master's degree in literature. Her commitment to weaving thought-provoking narratives based on field reporting and supported by data and research in health, science, gender, and development issues has earned her several media fellowships, including the well-known Ladli and Survivors Against TB. It's our pleasure to welcome Anuradha Mascarenhas. Please come in. Though she doesn't require any introduction, I would be failing in my duty if I do not introduce Dr. Soumya Swaminathan. A short profile. Soumya Swaminathan was most recently WHO's chief scientist and before that Deputy Director General for Programs. Returning to India, she took over as chairperson of the MS Swaminathan Research Foundation, MSSRF, in February 2023. She is a pediatrician from India and a globally recognized researcher on tuberculosis and HIV, and she brings with her 30 years of experience in clinical care and research and has worked throughout her career to translate research into impactful programs. Dr. Swaminathan was Secretary to the Government of India for Health Research and Director General of Indian Council of Medical Research from 2015 to 2017, when I was also serving in the Government of India, and we had a lot of occasion on which we used to interact on health research. In that position, she focused on bringing science and evidence into health policy making, building research capacity in Indian medical schools, and forging South-South partnerships in health sciences. From 2009 to 2011, she also served as coordinator of the UNICEF, UNDP, World Bank, WHO special programs for research and training in tropical diseases in Geneva. She received her academic training in India, the United Kingdom, and the United States of America, and has published more than 480 peer-reviewed publications and book chapters. She is a fellow of the US National Academy of Medicine, the Academy of Medical Sciences of the UK, and a fellow of all the science academies in India. She has received several honorary doctorates, including from Karolinska Institute, EPFL Lausanne, and the London School of Tropical Medicine and Hygiene. She serves on several national and global advisory bodies and communities. She is an adjunct professor at Karolinska University in Sweden and the Tufts University in Boston, USA. She is a board member of the Alliance Bioversity Coalition for Epidemic Preparedness Innovations, CEPI, FIND, Population Foundation of India, and others. She is also a governing council member of the Tamil Nadu Climate Change Mission and chair of the ICMR Scientific Advisory Board. As WHO's inaugural chief scientist, Dr. Swaminathan built the science division with a focus on research, quality assurance of norms and standards, and digital health. She played a key role during the pandemic in coordinating scientific efforts at the WHO as well as in setting up COVAX with a focus on equitable vaccine distribution to low and middle income countries. It's a great pleasure and honor to welcome Dr. Soumya Swaminathan.
So thank you so much, Mr. Chandramouli, for that uh, introduction to all of us. And I'm sitting here with the author and the subject, so I really don't know what I'm doing here, but it's a pleasure to be on this platform with both of you. Of course, we do say she's our Soumya. Now we started to saying our Soumya, who needs no introduction. And Mr. Chandramouli has talked all about her achievements. And what I'd like to add is how Soumya has become a household name, recognized in every household all over the world. And the reason for that is the way she handled communication during the pandemic. As we all know, there was total chaos, there was misinformation, disinformation, and she took it upon herself to literally put herself in the firing line, if I remember, even though it was virtual. I think shots were being fired, but it was the air of calm, sanity. She communicated things in a very calm manner with no over reassurances that everything was going to be all right. Neither was she alarmist. Everything that she said was based in science. And that is the thread of this book, actually, is what Anuradha has traced very beautifully from childhood, her passion for science, her passion for integrity, and her passion for the truth. So I think this is something that really emerged from the book, and I found that the most inspiring as part of your book, Anuradha. So with that, I think that as we keep discussing it, what will emerge as we discuss this book is that what we see in the future has to be based on fact. How technology, innovation, and science are really the foundation and very, very strong foundation for anything further we do, not only in public health, but in any other areas of interventions that we deal with. So I will now go to Anuradha Mascarenhas, who said, I've described her already to some of the people here as one of the earliest health journalists in my knowledge, because I remember that there was no such thing as health journalism. If there was an outbreak of something, cholera or malaria, it would be discussed and you'd find a short in the news or briefly. That's where that would be. Sorry? It would never be page one. So I remember very early on, she attended fellowships. She found a passion in health journalism, health writing, which again comes back to having verified news and information out there for the general public to take. So I think it's very, very timely, and it's such an interesting book. I read it 2-3 times as saying this is like an open book exam for me. But the thing is, she's woven very nicely personal anecdotes from Soumya's childhood about her very illustrious family and, sitting around the table, doing things together, the 3 very, very famous sisters. And you've woven that very nicely interspersed with all the defining moments and the milestones in her own career and how it is, what kind of impact that she's made on health research in India and world over. So I found it a very, very interesting read, Anuradha. I'm very happy that you're here too. So I think that before we go into the book itself, maybe I would like to ask Anuradha first, what made you want to write this book? And no, you should let us know why, because today's discussion is on your book. So let's hear from you.
Thank you so much. First of all, I would like to take the opportunity to thank Dr. Chandramouli, the team at Chennai International Center for this wonderful event. Thank you so much. Nalini ma'am, thank you. It's wonderful to meet you after so many years. And special thanks to Dr. Soumya Swaminathan. this book wouldn't have been without her support, her incredible patience with me. So I I don't have words. I really don't have words. And please allow me 1 second to just express my heartfelt appreciation for my husband, who has come all the way from Pune to Chennai for this event. Thank you so much. So, as for the book, um, of course, we know that there were a lot of bad days in COVID, and everybody's had personal bad experiences, etc. So, I won't get into that. But, like most experts have said, that there were a lot of opportunities, whether it is infrastructure development, etc. So, when an opportunity came by, I decided to take it in terms of writing a book. The publisher wanted me to write something, in the context of a COVID pandemic. I don't know why, but Dr. Soumya Swaminathan came in my head that time. I mean, ma'am, this is no flattery, but as a journalist, like as a young reporter, we would be, I'm from Pune, so I would go to Beach Medical College, I would go to NARI, I would go to NIV, NCCS, etc. We would meet a lot of experts. We would kind of interact with them, understand what their studies, research, etc. So, these things stay with you. And I particularly remember, I don't, whether it was a foundation day lecture or what, but ma'am was there at BJ Medical College. And I actually kept my pen and paper down because that time we didn't have that recording thing. And I heard her. And she was speaking about TB. And the way she spoke, with what passion. And the fact that nutrition is so important. This was then when she was DG ICMR. And somewhere these things stay with you. And today the Russian trial is proving that, it has reduced the infectivity rate and all that. So when the book, we decided to talk about the book, so kind of there was a brainstorming. And I said, why not her? She has been DG ICMR. She's the first woman WHO chief scientist. I mean, forget the woman also, but she's the WHO chief scientist, which is like a big thing. And of course, there's a lot in the public domain about her. But there's no book. So why don't we attempt? And to tell you the truth, we wanted her to write it. We wanted her, it to be a memoir, to kind of be her in the first person narrative. And she was so reluctant. We had Zoom calls, we had meetings, and the publisher said, Dr. Swaminathan, we'll do this, we'll do that. But I think she was on the last, she was at WHO and she was on her way out. She was extremely busy. And somewhere I thought that, as a woman, how did she deal with all this? Doesn't she get angry? Doesn't she get irritated? Doesn't she get frustrated? Or, so many things at home, at work. How does she manage all this? I mean, what is kind of a support system? I was interested in the personal part of it. I was interested in the professional part of it. Of course, her work in the field of HIV and TB, I don't have to, everybody knows about it. So just that journey in science, in research, in, all this decision making and her leadership, I was really interested in exploring those facets. And yeah, that's how the book came about to be. And I'm really grateful because we really had to persuade ma'am to come on board. And but I must say that when she did agree, she allowed me access to her family. I was so privileged to meet Dr. Swaminathan. Unfortunately, he passed away before the book was published. And I really wish I could have met Meena Swaminathan. I mean, when the ma'am spoke about her and Nitya Rao spoke about her, I mean, she emerged as such a presence. Of course, I spoke to her sisters, and then she also exposed me to a lot of global scientists who would kind of, some aspects of ma'am which I don't think people know much. And like the way she used to walk and walk and walk and trek and trek. So all these things emerged. It was so interesting. And of course, I met Dr. Ajit also. And so that's how the book came about. And I just believe that if you're passionate about something and you want to do something, then somehow things happen. And then the book happened.
And Soumya makes it look very easy, right?
It was handled.
So we'll deflect back from, I think we're thoroughly embarrassing her. So put her back in her comfort zone, which is science and medicine. And I just want to, I mean, it might sound like a very silly question, but what was it? Because in the book, in her first job as a clinician, as a doctor, I think, in the ward, she found it very strange that it was all care. Not that clinical care is not important, but there was no, affiliated research. There was nothing based on data. And her first job itself, this young Soumya started wondering, why is clinical medicine and medical research not linked the way it should be? And Dr. Yadav also, I think, both of them set out together to decide, and because they decided that clinical research is fundamental to clinical care, and it's not something that is set apart. Would you like to tell us about your thoughts, how you developed this whole thing and realized the importance of research both in your personal career and for the community at large?
And also to add to her, because it's going to be like a conversation, ma'am, do you think things have changed over the years? Clinical research and in terms of patient care?
So thanks again very much to CIC for hosting this event, and of course to Anuradha for her persistence and her passion and commitment also to both health reporting and of course to this book. I mean, I think single-handedly she has done it, and it was difficult for her because she had to find time with me, and it was intermittently whenever especially on Sundays, if I had some time when I was in Geneva, then if I was traveling somewhere, I was going for an evening walk, I would spend the time, talking to her while I was walking. Connectivity would go. Yeah. So I was either on a train or walking, I think, whenever I spoke to you. So that's how she collated all the elements. And then it was mostly done, I think, when in 2022. And then 23 was spent writing, putting it together, editing it, and so on. So, and I think she's also captured many things, I think, which from childhood, etc., which do have reflections later on. So I think my interest in research was probably seeded very early because of where I grew up and the fact that we grew up on the campus of the Indian Agricultural Research Institute, and there was never a time, I remember, when there were no students in the house, all carrying fat theses and waiting for their turn to discuss the thesis with my father. So it was, for us, it was very natural that that was the way life unfolded, that after school and college you got into research, and we used to go to the fields, we used to go to the animal labs, to the genetics lab, etc. So I was very interested in, especially in genetics research, and I also had an opportunity as a child to go to, well, as a high school student, to go to Calcutta one summer holiday and spend a summer holiday in a genetics lab where they were looking at human genetics. Those were quite primitive days, mid-70s. We didn't have the kind of sequencers and the kind of technology we have today. So very simple, everything was done by hand, but and there were very limited diseases you could diagnose like that, but still it was possible to pick up some diseases, some genetic inherited disorders. And so for me, that connection between what you see in the clinic, what somebody is suffering from, and what you can do in the lab to find out the root cause and treat it was very inspirational. And so that, I think, continued to want me to do research. The medical part of it was more actually by chance. It happened. It wasn't that I wanted to be a doctor or anything, but that was what I turned out doing, because also my friends, everyone was writing the entrance exam. So I did that, but one of the few people to have finished MBBS and then wanted to continue to do research. So of course, I also did MD. And then I discovered through my MD that there wasn't this environment for a lot of research exposure or training, or even anybody who's, even though I studied at the All India Institute of Medical Sciences, where many of the faculty members, if at all in any other institute, you'll find in AIIMS that people do research. But still, I didn't find it at that level which I was expecting. So, which is why I decided, okay, we go for a fellowship abroad and get some more in-depth exposure into some really solid research methods, and then come back to India. But when I did come back to India, again, I faced the same situation here, where people were very puzzled and mystified as to why I would want to do research when it was clearly a flourishing clinical practice was what every young medical doctor aspires to, especially if you've had a good academic career. Then people certainly, and if you've specialized and super specialized, then the logical thing is to set up a practice or be attached to a big hospital. And that didn't excite me at all. I didn't want to do it even for one day. And so it was actually very challenging to find an opportunity and an opening in an institute which gave that freedom for research. So even today, I think you were saying, have things changed? Maybe they have to some extent, but not enough. So if you really look at health research output or medical research output from India, we're nowhere actually in the top few countries, despite the fact that we probably have the most amount of clinical material that's available. We have human resources, we have excellent physicians, we have excellent hospitals, and yet we're not doing anything earth-shattering in terms of medical research, or not enough, I would say.
But ma'am, when you were the DG ICMR that time, you had set up this project so that, clinical, especially Dr. Katoch, that's what we have said in the book. So do you think there has been any feedback or,
No, there's been some improvement incrementally. I mean, the government budget for health research has gone up again, but we know that the health budget itself is 1% of GDP. So if you look at health research budget, it's like a fraction and a fraction and a fraction of that, compared to the NIH budget, for example, of $40 billion a year. So forget about the same league. I mean, we're nowhere. Considering the complexities of the challenges we have in our country, our investment in health, and whatever is invested is from government. There's very little investment from private sector in health research. It was only during COVID, I think, for the first time that some of our companies actually did some R&D, serious R&D, and were able to produce, products, because our pharmaceutical companies are mainly into generic manufacturing. So the technology is basically about how to make affordable quality drugs and vaccines. It's not about developing new products. But during COVID, I think they were challenged. The government also put in some money, and so there were some new products that came out of India. It was a DNA vaccine. I think the only DNA vaccine to have been trialed was from Zydus Cadila. There was mRNA vaccine from Genova. So I hope that trend continues, because traditionally we have not had a lot of R&D.
But ma'am, since we're talking about learnings also from the pandemic, so this kind of major learning that, research, and do we have to wait for another disease? Do we have to wait for another pandemic? I mean, where are we in that respect in terms of research that can be translational and can help?
Yeah, so the danger, of course, is that we go back into this cycle of panic and neglect.
Exactly.
You panic when something happens. When Nipah happens, everybody panics, everyone rushes there. But when the outbreak is controlled, and it's very difficult to convince policymakers to invest in preventive healthcare and public health, because these are all things which are invisible if done well. So, but if you don't do those, then of course you get problems which then become very visible. But all your investment, whereas putting up a big hospital is very visible to the public. And so that is a preferred option for politicians rather than investing in primary healthcare and public health.
I also want to sort of put this forward that we make research into something about, scientists sitting in an ivory tower. I had the fortune for being trained in my MD curriculum under Dr. K.V. Thiruvengadam, who would simply, during the wards round, he would notice a trend, he would notice the numbers, and he gave me a project, said, Pare Raja, just look at the movement. It's called the Elenese, the movement of the nostrils, and see whether it's linked to patients with emphysema. It's a simple marker. And how did he do that? Because he looked at 100 patients with emphysema, and even without a chest x-ray, he would say this patient is emphysematic because of the way his nostrils are moving. Now, that is fundamental clinical research, and everything that we did when we studied and worked with Dr. Thiruvengadam was observation and listening, which is another thing that we have found in interactions with Soumya, that it's important to observe a patient, it's important to observe trends, and it's important to listen to what the patient and the community says. Another example I wanted to say, when we were working in TB and we wanted to take the treatment closest to the community, so we started working with private practitioners. Then we thought, why not involve pharmacies? And because patients go to the pharmacy, buy medicines for a month or so, run out of money and stop treatment. So we said, why don't we make them the providers, them the mentors to look after these patients? So we submitted to the Central TB Division Operation Research Protocol for involving pharmacies. This was about 15 years ago. It was just rejected because, you know, I'm not belittling anybody, but I'm saying as an NGO, it's just an observation we made based on which. So what I'm saying is it's like a chicken and egg situation. You need to have initial observations, initial data, which may not be brought up by a scientist or a super scientist, but just from someone in the community, which is now what we call participative research. So somebody very much in the field can throw up observations, which I think as clinicians and then up the ladder of research, you go to the scientists and you go to, you know, the teams of medical research could easily pick up on these things. But what happens is I think they're so separate. To answer your question also about what's the future of medical research in India.
But I think what Dr. Swaminathan has also explained very well is that how you have to convince the policymakers that this is so important. And she's given given a fantastic example. In, you know, she had these files, and she was there was one particular file from the National Institute of Virology, and they were supposed to set up the BSL-4 lab or BSL-3 lab or something like that. And you know, that file was pending, and then she got angry, I think, right, ma'am? Yeah. And then you said that, you know, if you are not going to approve this file, then I don't know. I'm going to shut down everything and let all the diseases come. I don't care. Something on those lines. And because of her persistence, today the NIV BSL-4 lab is there, which actually did the isolation of the SARS-CoV-2 virus. So I think that was like huge. And I think that persistence paid off.
That's the same thing, you know, where the finance department is always trying to cut down expenditure without really understanding what the implications are. So set up a lab like that and run it is expensive because it's a high containment facility and it's only one in the country. So somebody in the finance ministry had put a lot of notes on, you know, this is a waste and why are we spending so many crores on it, etc. So this is why I had to go to the secretary at that time to explain that there's only one lab, and if that shuts down, then India doesn't have any capacity to look at these kind of dangerous pathogens. So of course he understood immediately because there were people under him who were putting these notes. So very often I think the things which are technically are the right things to do don't get done, and the priorities go elsewhere. But I think to get more people interested in research in our country, I think it's probably a problem across all disciplines. I don't think it's only medicine. And also we need more interdisciplinary research. And I think now there are, I think, a lot of private universities in particular, who are coming into it. But I think our exposure and training to research has to start from school. And kids really have to get excited about, yes. That is, you have to ignite that spark at a young age, otherwise it's very difficult. Yeah. And as you said, in clinical research, often it's just a matter of observation and keeping good notes, and then studying those notes and using your analytical capacity to make some hypothesis, which you can then validate. And you don't necessarily need a very big infrastructure. So in India, there have been many examples of people working in remote areas who have done, groundbreaking research which has actually changed policy. So that's the other thing. Many people think, you have to have a lot of facilities, you have to have a lot of resources to do good research. But it's actually just the motivation and then asking the right questions and having good observation skills. Yeah.
So would you like to kind of take this forward, or should we talk about the other aspect of...
I'm just wondering whether we should jump into the most exciting... I noticed that when this poster was made, we also had a stamp across saying lessons learned from the COVID pandemic, which I think is a contribution for us to focus this discussion from the CIC itself. So maybe we can go back and forth a bit on that. And so Soumya was in the hot seat, as even Anuradha has said. Would you like to sort of the thought processes with which you evolved this whole story of Soumya going to the WHO and then becoming the chief scientist and this whole gamut of things that happened? Would you like to take us through that, which from your book?
Yes, so I mean, of course, I was a little shocked also when Dr. Swaminathan said, "Oh, when Dr. Tedros called," and I was like wondering why is he calling me? And then when he told me that he wants me to join the WHO, and after some time I said, "No, I don't want to go because I want to complete all the work here back in ICMR." Okay, here's this lady who's rejecting a global opportunity. Why? And the solid examples that she was giving me in terms of her work in malaria, she was very interested in what she had set up. She was very interested in what she had set up at the TB consortium. She was very interested in the Indo-Africa dialogue and a lot of work which she had taken up, and she was so passionate about it. So one can understand that reluctance to go immediately to WHO. But then eventually, I think Dr. Swaminathan also convinced her, and then, by those examples as to how she then, was. And immediately, then she was like second in command, I think, ma'am. DDG is like second in command. And so I think it's better if Dr. Swaminathan talks to us about that and, what those challenges were, especially as DDG, because it was very difficult. And Dr. Swaminathan has also said in the book that, there are a lot of challenges that she faced in that score. So that would be, I think, very interesting. Before, she set up the science division and she became the chief scientist. So how did she deal with that?
So the WHO is an interesting place. Of course, it's a huge bureaucracy. But the good thing about it is it's very technical, and it's focused on real work and on solving people's problems, and it's full of very wonderful people who are all very committed and passionate. So that's what I really liked about the WHO. And when I first went as the deputy, as she says, Dr. Tedros just called me up one morning and said, "Hello, my sister." And I said, "I don't know who's this person. Hello, my sister." And then then I realized later on that in Africa, that's how you talk to each other. Hello, my brother. Hello, my sister. But for me, it sounded strange. And then I had only met him once, very briefly. And then he said, "Will you come and be my deputy?" And it was completely a shock. But I realized later that that on the technical side, it was perfectly fine to handle all these things. But there are other aspects of WHO. One is that there are 3 levels of the organization. So there's the headquarters in Geneva with about 2,500 people, mainly making policy guidelines, standards, recommendations, etc. So all the normative work is done in Geneva. And that's where the World Health Assembly meets every year. That's where the health ministers come. And there are hundreds of expert advisory groups that actually help the WHO in the technical work. Then there's a second level, which is regional offices. There are 6 regional offices, and each region has a regional director who's elected by the member countries of that region. So for us, we are in the Southeast Asia region, 11 countries. We have a regional office in Delhi with a regional director who's elected by the countries, not appointed by the DG. So there's another power center here. And then you have the country office. We have about 150 country offices. WHO has 150 country offices, some large, some small. And there's a country head, and then so you're operating at these 3 levels. And I very quickly realized that there is a lot of politics and a lot of bureaucracy, and there's a protocol to be followed in who talks to whom. And so my first instinct is always to pick up the phone to solve a problem. And so I did that a couple of times and realized that no, the DDG cannot pick up the phone and talk to somebody in a country office. You have to first call the RD or somebody in the RD's office. Then it goes through a lot of things there. Then that person will decide who's in the country. The whole thing takes 3 weeks for the message to go down and come up. Something I felt could be solved very quickly if there was a 3-way call or something like that. So there were many occasions like that where I was told, no, there's all wrong protocol that you're following. But the other thing I realized was within WHO, the silos, the very protective, people are so passionate about their work that they become totally protective and they just want to keep it to themselves. So it needs somebody from outside to come and say, no, what's the final outcome of this? Or what do we want to achieve? What's the point of just keeping it to yourself? You've got to open up and let others come in and help take this forward. So a good example was the non-communicable disease department, which always talked about 4 risk factors: lack of physical activity, tobacco, alcohol, and poor diet. And I knew that something was missing, and that was air pollution. And so I spoke to our environmental health colleagues, and they said air pollution is the biggest risk factor today globally in terms of the number of people who get impacted, even more than tobacco. So I said, okay, so are we not talking about this fifth very important risk factor? And there was no reason except that there were two different departments who were handling this. And they had been apparently having this discussion but coming to no conclusion. So I then said, no, this is ridiculous because we're going to the UN. In a few months, we were going to take a big paper to the UN. The UN, of course, the heads of state come there to New York in September every year and sign off on various resolutions. How can you go with a resolution which heads of state are going to sign without even mentioning this most important risk factor? So we managed to sort it out. But if I hadn't intervened or somebody hadn't intervened, it would have been a huge missed opportunity. And similarly, there were other examples, and there were also a lot of pressure from member states. So very often you'd have the ambassador knocking at your door and say, yes, ambassador, what can I do for you? And it would be like, I don't like this document of yours because you're saying something there which usually it's something which affects the trade interest of some country or something like that. So no, you got to change that language, or you've got to change the statistics, or, we disagree with your assessment of our capacity or whatever it is. So that was another aspect of the work there which one had to handle diplomatically.
Did you get stressed out? I mean, did you get worked up with all this?
No, so I think thanks to the experience in ICMR, which was equally onerous, where you're dealing with the same issues, luckily I'd had 2.5 years experience there. Okay. And the other experience I'd had was handling the media in ICMR. So I had decided that I would be very open with the media, because I felt that unless you talk to journalists, how are you ever going to convey what an agency like the ICMR does? I think after COVID, everybody knows ICMR just like they know WHO. But before COVID, I doubt that ordinary person on the street knew anything about ICMR. So I had said, no, let's be open. But then very often when you do that, the downside is you'll get a headline the next morning, which is, not exactly what you said, or it would have twisted something you said, or it would have made it very sensational. And so very often colleagues would ring up and say, why are you talking to the press? There's no reason. Your predecessors never spoke to the media. Why do you have to go out of your way? And then, look, this is what happens. You get headlines and you'll be in serious trouble with the government. So I said, it's okay, because you have to take the good with the bad. So I think that also helped me during COVID, because very often this is what would happen. You'd come under severe attack, especially with social media. There was a lot of harassment on
so
social
when you
media.
became I'll come to that point later, but you, from the DDG, then you became the chief scientist. So that transition, if you could tell us a little bit beyond the book.
So because when we all joined as a new team, so Tedros felt that the WHO needed reform. He called it transformation. And so we went through a process which was very long. It took more than a year. But at the end of it, a few key things emerged. And one of them, which was a good one, was that science should be given a much stronger platform, much more visibility, because science is very much part of everything WHO does. And so that's when there was this suggestion from somebody that a chief scientist position be created, that a science division be created that would work across the organization. So this happened in March of 2019, and the transition was good, because for me, I think that was a much more interesting position and profile, for considering my own background. So we started working on the science division, the strategy, and digital health was a very new and important component. How are we going to handle AI in terms of health indications? What are the ethical aspects of things like genome editing and artificial intelligence in health? So there was a lot of ethical issues about new technologies, which we felt the science division must handle. And there was a lot of things to do in research, as well as in the way that WHO does guidelines, because WHO is often criticized for being very slow and not very nimble, etc. So we said, how can we use technology also to make our guidelines much more responsive and updated more frequently? So while we were doing all of this, of course, in 9 months, we were into the pandemic, and there was no playbook for a scientist, chief scientist, or what a science division should do during a pandemic, whereas a very clear playbook for the emergencies program. And the emergencies program was fully into it. They know what to do, where to gather information, how to write the protocols. So in the beginning, it was not. So I was trying to figure out what would be most helpful for the emergency department people. What could we do on the back side that could help them? So we were doing all the literature reviews. So as you remember, in the early days of January, so much of uncertainty. There was not much information coming out of China. Even WHO was not getting the kind of information we needed. And so we really had to use all our personal contacts and calling people at all hours of the day and night to find out what was happening. And slowly the picture was emerging. And then by the 10th of January, we knew that it was a novel coronavirus. So after that, it was like every day some information would start trickling. And I must say the Chinese scientists were good, even though the government was being very sort of obstructionist and opaque. The scientists were publishing. So they were, by the third week of January, we had articles in the Lancet describing the clinical profile of patients admitted in Wuhan. And we already knew by then that, it was affecting the older people much more severely. We had a hint that, it was spreading. We knew it was spreading person to person. And we didn't know what drugs are working, etc. But we knew that intensive care will be needed and things like that. So all our early information came from the Chinese scientists that we were in touch with on a one-to-one basis through phone calls. And it was, they were taking risks because they were talking to us without approval of their government and so on. But they felt that that was the right thing to do. So,
but what were the stumbling blocks, ma'am? Why did you, especially when you have been talking about the airborne transmission of the virus.
Yeah.
And you were particularly upset that WHO did not, take, because like you said, that they did not have a rule book or, playbook or whatever, and they had something on influenza viruses. So why is this lag? Why? Because you've been there. You've been in the...
So I think there are a few reasons. One is that for a large organization like WHO, the wheels move slow. It's very difficult to make the wheels move faster. The second thing is that WHO works through its external advisory bodies. So for something like infection prevention and control, you have a committee. And you have to generally go with the committee's recommendations. It's not individuals within WHO who start writing guidelines. It's the committees. And so the committee, it depends on the composition. And one thing I realize is that most committees are made up of people from the high-income countries. So again, Tedros was trying to change that. So the perspective of the low-income countries is often not taken into account. So I think a lot of our early recommendations and were all oriented towards, because the first thing was China, then next was Italy, and then was the other parts of Europe, and then of course in US the cases. Whereas we were not looking so closely at Southeast Asia. How did Thailand do? What did South Korea do? What did Cambodia do, etc. Or India. So I think there is a lack of very broad participation in those advisory committees.
And then in this respect, then how did you start addressing the media? Because you did become the face of the science division
so that
of
came
WHO.
a bit later, because in the beginning, it was the head of emergencies who used to address the media, and they had daily press conferences, as you know, because every day there was something new and the whole world wanted to know. So it was somewhere around end of February. Middle of February, we had a very big global meeting. Actually, people came in person. At that time, we had still not banned travel, etc. Or countries were not banning travel. So 10th and 11th of February of 2020, we had a global research and innovation forum where we produced the first roadmap for research on SARS-CoV-2 with all the knowledge gaps that needed to be filled, so that there could be scientists around the world could be very clear, this is what we need to do. They could start collaborating and working on things together. So that was the first time that actually I think I had a media opportunity, because the world's media was there to find out what's happening. That was the same day that SARS-CoV-2 and COVID-19, those two terminologies were also announced. And then from then on, I think because there was so much new science coming, that is when then Tedros said, you need to start the media. And also he felt that as a chief scientist, talking about the science would make it difficult, because he was being attacked politically. And so it was quite difficult for him. He was really being attacked on all sides. The one thing he did do was to back me fully and said that if you are convinced about the data and you want to make a statement, regardless of which country will be upset or who will be upset, you go ahead and you will have my backing.
So how did you
Yeah.
prepare for all this? I mean, this is like a huge task, no? I mean, tell the world. So how did you prepare? I mean, personally speaking, like the day would begin and then you have to address all these things. So, what thought process was going on in your mind? And when, the solidarity trial, or for instance, there was a
Yeah,
lot
so
of feedback
the main
from
thing was that
WHO.
you had to be on top of all the data. That was the most challenging thing. How much can you read in one day? How much can you absorb? So the only thing I used to worry is there something I've missed, because I shouldn't be misinforming people. So we always used to say, today this is what we know, but tomorrow we may know more, or we may change what we are telling you today because of the new findings. So nothing is in stone, nothing is like forever. This is an evolving thing. So that we kept repeating that, because people would otherwise say, oh, you said this yesterday and now you've changed your stories. Media doesn't forget.
Another major milestone, I think, was setting up the COVAX system. Could you tell us how, because people have been working in silos and companies are very possessive about their own processes and their own research. Just like you said, there was an open platform for people to start contributing. This must have been a mammoth advocacy task, which I think you had played a huge part in this setting up of the whole system to get different vaccine companies to actually start working and come together to produce the vaccines which were then utilized. Could you tell us a little bit about that whole process? Because it's very daunting, I think it's a superhuman feat that was pulled off. I think never in the history of public health have countries collaborated in response to something like that. So can you tell us a little about that?
It's true that on the one hand, we were working on the science, the clinical trials, like Anuradha said, the solidarity trial. How do we get countries to work together and doing more research, finding out, we didn't know what drugs to use, right? So we really needed the clinical trials to be done. And it was in June that the UK group had found that corticosteroids, dexamethasone was effective in reducing deaths. But at the same time, we knew that if a vaccine were to be developed, there would be a massive problem globally, because there would be shortages, and that there, in the past, going from history, the high-income countries or the countries with a manufacturing capacity have always had the first dips and the whatever's first rations of that, and that low-income countries have always been the last. So this happened with HIV/AIDS. If many of you remember, that treatment became available in the US, in the 90s, in the mid 90s, and it was priced very high, and there was a feeling that Africans and other people in poor countries would not benefit from these drugs because they wouldn't know how to take them, or they wouldn't be regular, and so on. So it took 10 years, before HIV drugs, and that was after a lot of advocacy and activism and thanks to companies like Cipla, which made it available at very low cost, that so many millions, could afford treatment. But so we knew, so WHO knew this, and so we said, how are we going to proactively do something about it? So this is when we developed this whole idea of the ACT Accelerator and COVAX, which was the concept was, and it was the first time I think that was done, and many people criticize it, but I think without COVAX, it would have been much worse. The idea was that you bring all the countries together and you have an agreement as to how this vaccines would be shared between countries as they became available. And that low-income countries should not be asked to pay, but some fund has to be created through donations, so that those vaccines can be distributed by Gavi to those countries, and those who can afford, those countries would purchase the vaccines, and that all the pharmaceutical companies should also collaborate with this central system, which would ensure the whole world got access to vaccines. So let's say one vaccine was developed somewhere in some part of the world, and you had 50 million doses available initially. where would those 50 million doses go? They would go to the people at highest risk of dying, regardless of where they lived. So you would distribute those 50 million doses by the population of old people in different countries. And then frontline workers, healthcare workers must get it. So that was the whole idea of what we called an equitable access framework. It was all beautifully developed. All countries agreed. Everybody said, yes, this is how it should work. But finally, when the vaccines got finished their trials and were approved, the countries which had already paid in advance, for example, to Pfizer or to Moderna or to J&J, they took all the vaccine supplies as they were coming out of the factories. Luckily, India had its own capacity, could manufacture. China had its own capacity. But China started vaccinating in July of 2020 before any other country did. They didn't wait for anyone to approve their vaccines. They approved and decided that they would. And they were also sending it to other countries who were willing to vaccinate. So the main thing of COVAX was, and what made it difficult was that they were relying on the Serum Institute of India to supply, because traditionally the Serum Institute is the largest supplier of vaccines globally. Nobody else has the kind of capacity that they have. And so the hope was that those hundreds of millions of doses will start coming, because Serum had already tied up with AstraZeneca to make their vaccine. But then the Delta wave happened here, and so that was shut. So for 8 months, there was no vaccine coming out of India. And that's how then COVAX was struggling, because there was no Pfizer, there was no Moderna, and the only other hope was Serum Institute. And then the others all were delayed, like Johnson & Johnson got delayed, Novavax got delayed. So there were other vaccines which were good vaccines, but they all got delayed getting approvals. So we had some very terrible times in 2021. Every day, some African country head of state would call WHO and say, when am I getting? And they would ask for small volumes of vaccine. They would say, I want to vaccinate my health provider. So many doctors and nurses were dying, but we didn't have any doses to send. So that's when a lot of people started criticizing COVAX also, because it could not deliver at that time. Eventually it did. But this is why now the pandemic treaty, which is being negotiated and should get finalized in May, is trying to address some of the problems. So one problem we saw was trade and travel restrictions. So the moment some country would say they've got a new variant, other countries would say, okay, let's shut down all travel and trade, and particularly if it was a poor country. So when the Omicron came out of Southern Africa, they suffered a lot. Even though it was completely irrational, we know that stopping air travel does not stop the spread of a virus. It's already gone by the time you detect it. And that's for variant after variant. We kept saying, WHO kept saying, there's no point putting trade or travel restrictions because the virus is already everywhere. So you have to do other things. So that was one issue. The second was this inequities and in sharing of products. Whereas in sharing of data, of course, the companies were saying, give us the data. We have to prepare the new products, which is true. But there is no benefit sharing. They want the data, but the benefit sharing was not there. And then the third big issue we faced was the misinformation and disinformation campaigns that were really, to me, that was a surprise and a shock that even before the vaccines were developed, there was an anti-vaccine lobby that had started lobbying. So I remember in some of the press conferences, Tedros used to say, we don't even have a vaccine. And the anti-vaccine lobby is already saying, don't take it, it's all conspiracy. They're going to control you and all that.
On an aside, I think our audience would also like to know, and I'm curious, what is happening with the vaccine story? Are there new candidates and the whole protocol of vaccination? And, secondly, there must be ongoing research between, for example, long COVID. But is there a strong linkage? I think all of us read in the media again, the linkages between vaccines and development of chronic complications later on. And it's very blindly people put the blame on the vaccination. What is the status of research right now, Soumya, in vaccine development and also in the follow-up of COVID?
And just to add to her, because there's been a lot of talk about, of course, ICMR has done the study, but vaccine and heart attacks. There's a lot of, again, misinformation. So if you could address that.
So I think the vaccine story overall has been a huge success for COVID, because no one, I think, ever imagined that you could firstly do it so quickly, that you would have so many vaccines available in less than 1 year of a new virus being, it's never happened before. Now, of course, we're more ambitious now. We're talking about a 100-day plan to make vaccines. So the world should be able to make a vaccine in 100 days when a new pathogen appears. But at that time, 1 year was just incredible. Secondly, so many vaccines were successful. Normally, you'll get one, or if you're lucky. And so vaccine research, I think, took a tremendous leap forward. And new platforms like mRNA, like subunit vaccines, like the DNA platform in India, these all were developed. And now people are realizing they can be used for a number of other diseases, not just COVID. So I think that really gave a boost. And it was because of the prior investments, of course. If the prior investments had not happened over the last 3 decades, this mRNA and all that would not have come up. Now, I think in terms of the misinformation on vaccines, obviously people are frightened. If you're healthy and you're being asked to take a vaccine, you would always say, do I really need this? Can I manage without it? Because supposing that small chance of a side effect. So it's quite natural to be a little bit afraid. And then once you've taken the vaccine, any symptom you get, you automatically, psychologically, you relate it. Must be the vaccine I took, a week ago. So all these heart attacks and things which happen, must be the vaccine. The fact is that in India, we are having more and more heart attacks among young people, even before COVID, because of the fact that we have such a high burden of NCDs, risk factors like hypertension and obesity, which is growing in the country, air pollution. But the average person doesn't relate it to that. They relate it to some incident which has happened to you, and that is the vaccine is something you remember. So it was happening before COVID, but now it got aggravated, probably because COVID itself has a lot of impacts on the cardiovascular system. And it is well proven through many studies that COVID increases the risk of heart attacks, increases the risk of stroke, increases the risk of diabetes, and many other degenerative diseases, including even dementia and Parkinson's. So it's quite scary that one virus is able to have that kind of long-term effect on people. And this is apart from long COVID. So long COVID is you continue to have symptoms, you don't recover from COVID. You have fatigue, or you have confusion, or you have palpitations. That is long COVID. But even if you recover, you're actually at a much higher risk of developing one of these diseases. So this is what the ICMR study showed when they followed up people with COVID compared to those who did not have, that the risk of heart attacks and even the risk of sudden death was higher. Nothing to do with the vaccine, but it is to do with COVID. But in people's mind, there is that connection with the vaccine is what they remember as the event, which is probably responsible. So again, one has to keep on, I think, communicating the findings from research studies, explaining them. Why do you say it's because of COVID and not because of vaccine? Because there's been enough follow-up studies done with all the vaccines that have been given to people. And we're very lucky that they've all turned out to be relatively safe. Not 100% safe. No, nothing is 100% safe, but extremely safe, I would say, yeah.
I think that's where the job, Anuradha's job comes in. We need health journalism.
Oh, yes.
Yeah.
In fact, I was just thinking about Sputnik all of a sudden. My mind was just thinking, okay, among all the vaccines now, should I ask this? Which was the best? But I think I'll keep that for another day. So when, unless you want to open it to the floor or...
Let's talk about the author for a bit. So, in the process of writing this book, you've had delightful conversations with the whole with her family, her colleagues, and a little bit about her romance with Ajit, all that. It's just I said it's going to be made into a movie very soon. Take it from me. So I told her, better
it's gonna
watch
be
your movie rights.
no, ma'am. I'm also going to be a surprise because I think by now you all should know that she's got a lovely voice, and I'm going to ask her to sing.
Tell me, Anuradha, how? No, before that, we will. I will give her some time to recover from that. Being asked to sing, I think that's a nightmare for anyone. Even if they have a lovely voice, to be put on the spot. No, next CIC meeting will start with a song from Soumya. I will buy you time. No, but coming back to you, this whole book, I mean, it's a great adventure you embarked on, and then you were hoping that Soumya herself would write it, and you set about it. How was it to? I just want to know whether there are any stumbling blocks or what the difficulties that you faced, and how you managed to get such lovely anecdotes from everyone. You've tracked down a huge number of people. Tell us a little bit, because we are here to discuss your book as well. And so tell us about your whole process, and how long did it take for you to write this book?
So, actually, if you actually take the time of conceiving the book, like in the sense between the publisher and me, and then from the time of the contract till the delivery of the book, like this is much before the manuscript came to you. It was a 9-month pregnancy, ma'am, and a very fulfilling one at that. So it basically we started in July, and I would, like how Dr. Swaminathan said, I would ask her on Friday because I knew she was very busy. So Saturday, Sunday, she says, okay, rather on Friday or Saturday or Sunday, one of these days, because I had to hear her story, no?
Yeah.
There is a lot of literature about Dr. Swaminathan, right from early days and stuff like that. But then a little beyond that, I just wanted to know, still at the end of the day, I still feel that, I could have asked her a little bit more on this, could have written that better, could have dug a little more deeper, some more things which personally, apart from being a journalist, but as a lay reader would want to hear, not just a scientist, for the lay person. Even a school book, a school student would want to read or something. So in terms of that, I just started thinking. And then, yes, I did speak to her sisters, and they gave me some wonderful insights into their early days.
Yes.
And how she would write those notes and, tell her parents. And so something very interesting. And then the TB chapter was very interesting, I thought. I really liked the TB chapter because, she was a young scientist, just come back. And these things, all of us do face. You have bosses who can be nice, who can be not so nice. And she did face some struggles in the TB days. And then how she boldly took on that HIV department, when nobody wanted to do it. And then she got a team. And then how she encouraged her young scientists to kind of take leadership positions and all. That is so inspiring. I mean, while I was writing it, I was inspired. Because it kind of, you tend to learn from somebody who you are also writing about. And these things actually really stay with you. Yeah. I mean, even something what her daughter said, Shreya. That I was confused. She says, I did my zoology, and then after that, my parents gave me a year to decide. They never interfered. They never, used their pull or anything to get me anywhere. But, this liberty, very few people have. But, she was very grateful on that score, despite the fact that, I used to ask them, I said, but your parents are not here. How much time did they give you? Like every child has this, did you fight with your mom? Did you this? So she says, I don't know how Ma does it. I mean, she's so empathetic. She's considerate about, other people's feelings and so that kind of feedback which I got, I think added a little color to the book rather than just dry facts. And
I always wonder what the dining table would look like with Professor Swaminathan and Meena auntie, and the three of them all, total intellectuals. Did you ever have normal conversations? It must have been amazing to be a fly on a wall there, because in all my interactions with Professor, it was so gentle, open, always had an open, you could just walk in. But somewhere, there will be a very sharp observation relating to our work, because he chaired REACH for many years. He will just remember the vulnerable thing, and on point he will say, "Ennama, what was that thing we discussed that day? Is that going on?" So I think it was a lovely mix of different kinds of, interests around the table. So, and I think we can't let this conversation go without talking a little bit about Professor Swaminathan and Meena Swaminathan. And
Oh, yes.
they just, I think, lived by example. And if you just see, I mean, Anuradha's book also substantiates the whole thing, that just like Shreya says, her parents never lectured her. I don't think they told you what to do, but they just lived as they did. And total involvement in the community and betterment. And it's such a standing example of linking science research to, the whole green revolution and the hunger project and all that. It's just linking your knowledge to what is happening and take it into the farmers in the field. I think there could be no better. I mean, we owe this homage to Dr. Swaminathan today as we sit and discuss Soumya. Soumya, would you like to tell us a little bit about your own, that environment which you grew up in, the three of you, Madhura, Nitya and you?
And also a little bit about your mom. How she's...
So I think one is, like you said, the freedom to do what we wanted to do and to find out by ourselves, to make our own mistakes and to select what we wanted to do. So right through school and all that, I never remember anybody ever telling us that, why don't you try this subject, or you're good at this. Academics was not the be all and end all. So I never remember being asked for marks or being congratulated for doing well or not doing well or anything like that. It was just part of life. You have to carry on. So I think the emphasis was on being a more well-rounded personality, and also we were lucky to have exposure not only to the scientists who used to come home, but also through my mother's work to go to construction sites where she used to work with labor, setting up creches for the construction labor through mobile creches, doing her preschool education work, and a lot of villages we visited, especially around Delhi in Haryana and Punjab. So that was fun for us because it was like a picnic going into the farms on Sundays. But actually it was part of my dad's work, but we'd go along and have a picnic lunch there and come back. So I think one was that freedom, and we were three daughters. We were never ever told that there was anything out of reach or out of bounds. Anything that we wanted to do, we could try. And my sister was a mountaineer, so she used to keep going off on these mountaineering expeditions. And my youngest sister was a active environmental activist at that time. This was in her school and early college days. So very often she would tell my father that I'll be protesting outside your office. So so in case there is something in the paper or something like that, you have to. So, but that was never an issue. And we learned to be, I think, considerate and all that from the way that they behaved. But my mother was a very different kind of personality from my father. So she was much more very open in her. She would not hold back, in the sense that if she thought that something was wrong, she would say it, and she would say it directly. She would not try to be very diplomatic about it. So they had very different personalities. So even with us, I think she would tell us when she thought that we were doing something wrong. And of course, we got the usual scoldings as children. But then they're both good listeners. So I think that's the other thing, that they wouldn't be busy telling you and talking about their things, but really letting you learn by observation and also listening to you. And so my father, I think that's one of the great things about him, is till the very end, he was such a good listener. And he would remember everything that somebody had said. He would never forget. And so the next time you met him, he would pick up from where, and he would, so even at the time when you were saying that I was reluctant to go to WHO, actually he was the one who said that it's a very different experience to be at the international level, because he also had that after working for many years in government. When he went to the International Rice Research Institute, he said, I was able to do so much for Southeast Asia on rice research. And, he was the first Asian Director General of the IRRI. There'd all been Americans before that. So he completely changed the approach of the organization with a much better focus on the problems of farmers in Southeast Asia that grow rice. So he said, you'll have a very different canvas over there, and you can have probably a much broader impact than working in India alone. So you should not think lightly about this opportunity. He never, of course, said that you must go or you mustn't go. He said you must consider it very seriously. Yeah.
I'm very happy that you went. So I think maybe to bring it back to, the final pages of the book, I think through their conversation, an agenda has already been set for Soumya for the future of health research and future, because I think Anuradha has, when you read the book, you'll see that she still feels the focus on TB is very important. The continuing of public health programs and sustaining them is also very important. Though I've in practice when I talk to Soumya, I've been aware, but a remarkable, an area of public health research that she's pushing for is now climate and health. We always see them as two different things, or we see climate change as an emergency, a disaster happening somewhere. And of course, we do look at heat exhaustion and flooding and things like that. But the whole a new concept, I think it's relatively new, not that much research and written about it, specifically at the population level, looking at the effects of climate on health, which is now started spearheading through the foundation. So I would love to hear, all of you to participate in this conversation. Before that, would you like to just tell us a little bit about that further thrust in research that you're talking about? This is more like translational and implementation.
Yes. So I think one of the things also I learned through the pandemic and also interaction through colleagues is really the lack of focus on the impact of the environment where we live on our health. And I've realized, it's a fact actually that most of our health is determined by the determinants, what we call the social, economic, environmental, and also now commercial determinants of health. So where you live, whether you have access to safe water, sanitation, clean air, good nutritious diet, these are the things which keep you healthy. And of course, you may need a hospital, but that is a minor part of your life. So that's why I think now my focus is really on linking those other aspects and trying to advocate for more investment and more action, which has to be intersectoral and multi-sectoral action. So, for example, it's the Department of Industries, road transport, agriculture, and others who really need to think about how do you minimize the air pollution that's growing in cities. It's road traffic accidents. By the way, India is number one in terms of road traffic deaths. And last year we had more. It's going up, not down, because I think our infrastructure is getting better. The roads are getting better and people are driving faster. And of course, they're not well trained. And so it's those costs of development. Again, we're cutting down forests, we're cutting trees, we keep on building more and more infrastructure, which is not at all suited for our climate and for our needs. So we've adopted a model of development, which I think was aping what was happening in the US, for example, whereas that model of development is a failed model. And today we're asking them that they have to change, they must cut emissions and so on. So I think we need to really look at how we can we have our own development model where people and their well-being is as important, if not more important, than economic returns all the time. That's a very difficult thing, of course, to convince because GDP is the one thing that I think is the one number everyone talks about. But actually, if you look at people's satisfaction, and my father always used to quote the gross national happiness quotient, that I think Bhutan was the first country actually to. And he used to say that is what any government should be aiming for, the happiness of their citizens. So for that, you need all these other things. You need the greenery, you need clean air, you need social contact. And that was another thing which suffered during COVID. So the loneliness and anxiety. And so I see, Shailendra here, it's the surveys that have been done now recently have shown absolutely sky-high levels of anxiety among young people in particular. And so both anxiety and depression, more than at any time previously. And all over the world, this is a trend, post-pandemic. So mental health is a very important issue, which again is neglected. And so these are the areas which actually need more investment. If society has to be a happy, and
But ma'am, also one thing is, what
Yeah.
about the elderly population? Because we are an aging population.
Right.
And if you're talking about mental health, because
Yeah.
pandemic showed how vulnerable the elderly were.
Yeah.
They were socially isolated. So in terms of the government, I'm not sure, but somewhere, please correct me if I'm wrong, but somewhere there was a study saying there's a map of life where the Stanford University or something, they designed that how the elderly also should be made functional. At that age also they should be working, and the government should ensure that they are financially stable. So do you think this could happen in a country like ours?
I mean, it has to happen. I think our proportion of people over 60 is still about 12% or something. So, but it's growing, as you said. In another 20 years, so with this demographic dividend we talk about is not going to last forever. It will last for another 20, 30, maybe 40 years. And then we'll become like other countries which have more older people than younger. So, this is the time really to invest in that. So, certainly.
So thank you very much, Soumya. We took the brunt of the conversation. It was supposed to be a conversation, and sometimes we made you speak a lot. We have about 10 minutes if anybody has any observation or anything to share.
Hi, thanks, Soumya. It's always a just quick question. I mean, from your vantage point at the WHO, you just mentioned the social economic determinants of health. This particular pandemic, the vaccine story was one thing going on, but obviously there was global lockdowns, a lot of people out of jobs, and you mentioned nutrition being important. Now, globally, how do you see that? I mean, that's the first part of the question. Now, obviously, this pandemic came along with the lockdowns that could have potentially affected the economics and what people could eat. Of course, the trade-off was you were not dying from getting affected by the virus, but there were other factors. And given that potentially there would be future pandemics, do you see any lessons learned globally in terms of how one might trade off, the desire to stay away from the virus alongside, the sort of economics and the social determinants of?
No, absolutely. And I think that was one of the problems of these so-called lockdowns, which initially were thought to work. I mean, it worked in China, right? I mean, no one ever thought that a lockdown would be possible in any other country. So in the first few weeks, I remember all my colleagues saying, yeah, this can only work in China. No other country is ever going to do this. And it worked because they were able to contain it, within a matter of 3 months. With a complete shutdown of Wuhan and a lot of neighboring places. But then you saw country after country actually putting that in place, because that became the playbook. That China did it, was showing to be effective. Let's do it. So then the high-income countries were doing it, and then it became, okay, this is the solution. So then this is where it went wrong. Because I think for a country with a large poor population, where even housing, everybody is overcrowded. You don't live in proper housing where, every family can comfortably live and food can be delivered to you. All that doesn't happen in a poor country or in a poor neighborhood. So I think that playbook being adopted around the world was wrong. There has been, of course, a lot of research now on what public health measures should be used. I mean, I think school closures was another very controversial one, where everyone closed down schools. But in many countries, the schools reopened in a few weeks. Like in Switzerland, the schools were closed for only 5 weeks. And the schools reopened because the government said the cost of keeping children out of school will be too high. And by that time, we knew small children were not severely affected. So there wasn't that much of a medical risk. They said the other risk to children not going to school is too high. And so schools were prioritized. Whereas in our country, we kept schools closed for 2 years. Despite the fact that there was enough evidence by then that it's better for children to be. There were so many children who missed their school meals, of course, apart from the fact they missed education. And probably I don't know how they're going to catch up, those who did not have access to online. This happened all over Africa. So this is what will be the economic impact of the pandemic, which will last for a long time, is that whole generation that missed out on education and nutrition through the social safety net. So I think we have to think very carefully, and really the science should be driving the public health. It was not. at all times. The science was driving the public health, but then people were doing things which may have been inappropriate for your own country. And WHO also, it's very difficult to make a guideline for the whole world. So that was the other challenge. And I said the model became what's working in a well-resourced thing was applied everywhere. Of course, schools, we were saying for a long time that schools should be opened and all that. But so the trade-offs. So this is why you need a interdisciplinary team making decisions. And people started saying, why is civil society not being consulted? Why are there no philosophers, bioethicists and others also sitting in these committees which were making these decisions so that the trade-offs could be considered? So I think there was not enough analysis done on the trade-offs. And now we've learned that lesson. Hopefully next time we don't repeat. We put in place measures. Sometimes you have to put extreme measures, but for a very limited time. Beyond that, you have to really think through, what is really justified.
Hello, ma'am. Recently, you wrote an article in Hindu. The title is "The Climate Crisis Not Gender Neutral." And then in that article, you have raised a question like, why does climate action need women actually? Madam, in the rural, women pushed to fight against water crisis, and then deforestation and malnutrition deficiency, and then greedy healthcare system, and how we have to make women to become civic and green politically empowered, ma'am.
I don't think I have this answer to how to make them politically empowered, but it's true that
In the article you have mentioned
article
actually.
I've mentioned. So the main point of the article really is that women are disproportionately impacted by climate change, and you can talk about whether it's household food and nutrition, or whether it is getting water. It all becomes responsibility of the woman, right? Getting the fuel for the firewood, making sure the children are looked after, plus taking care of the farm, taking care of whatever livestock you may have, animals. All this becomes a woman's responsibility. And so now what we've done is recent analyses to show that women's health and nutrition really impacted by exposure to drought, floods, cyclones, and so on. But at the same time, the women cannot be only treated as victims. So the whole point is that there's no point saying, oh, poor things, these are very vulnerable. Yes, they are, but then what are you doing about it? Policies have to start becoming gender smart. And many of our policies are. Yes. So if you have only men making decisions, Yes. So we do need equal representation of women. Very important. Whether it's local bodies, panchayats, at the level of bureaucrats, administrators, and politicians, our MLAs, MPs. If we have good representation of women, many of these issues will come up into policy. So I think that's the point we're trying to make, and also decentralization of finances as well as decision making to local bodies and panchayats, because they know what their local problem is. Better solved than somebody sitting far away in a city, dictating how they should spend their resources. I think those are the major shifts we need to make, but these are very important political shifts, but they should happen if we have to really empower the community to take responsibility, provide for themselves.
Two questions. This COVID pandemic, I'm sure you've been asked this before, is it a natural phenomenon or was it a human error? The second question is, which according to you, data-wise, was probably the best vaccine which was produced? How good was our Indian vaccines compared to the ones in the West?
So the first question, where did COVID come from, where did the virus come from, has not been definitively answered, because the investigations into the origin of the virus have not been concluded, and that's lack of cooperation from China. So despite all the best efforts of WHO and all the international agencies, we've not had access to all that data. Now, most scientists believe that it's a zoonotic virus, that it actually jumped from an animal to human, that it may have originated from bats, because bats carry a lot of coronaviruses. But the bat coronavirus came into some animal, and then it got adapted, and then from animal it jumped to human. That's the hypothesis, but which animal we don't know. For SARS-1, it was finally found out that was a civet cat. And what happens in China is because of the practice of wet markets, where a lot of live animals are kept together and then they are just sold live or killed immediately just before selling it, there's a lot of possibility for this virus because in very cramped quarters, a lot of live animals under huge stress are being kept in these markets. So one of the recommendations was shut down these wet markets, but we don't know if that happened or not. So that was so 99%. I think people believe it came from an animal. It was a natural jump. This has happened, and if you've been reading the news, now there is H5N1 circulating among cattle in the US, wide circulation of the H5N1 flu virus. And so there's a lot of concern that once it's in a mammal like a cow, then the next jump to a human is just one step away. So it's important to get to the bottom of it, but we haven't got to the bottom of it. The other small possibility is that it was a lab leak, accidental leak from a lab in Wuhan that was researching coronaviruses, that they had somehow this virus in their stock, that it escaped from the lab or it infected one person in the lab and then it spread. There's no proof for that. The third is a conspiracy theory that China actually created this and released it. That nobody really believes, except the conspiracy theorists. No scientist really believes that. So those were the three hypotheses on the table, but definitive proof we don't have. On the vaccines, I would say that overall, like I said before, we were very lucky that not majority, but a lot of the vaccines that went into development actually were turned out to be successful. Of course, the ones that came out early had the advantage of capturing the market. But there were a lot of vaccines that came later that were shown to be effective, but by that time the market was already full. In terms of best, it's very difficult to say. They were the top 8 or 10 vaccines that were widely used around the world were probably all more or less very similar in terms of efficacy against disease. And none of them were good at protecting infection. Like even if we've had 3 doses, 4 doses, we can still get infected today with COVID, right? So no vaccine protects us against infection. They all more or less protected against severe disease. Maybe a slight difference in efficacy of around 5%, 8%. But I think that overall they did the job. All the vaccines that got approved were good. Otherwise, they would not have been given the green light, by WHO. Some took longer because of issues with paperwork and being able to submit dossiers and things like that. Yeah. There wasn't one like outstanding. In the beginning, I thought of excitement because the first 2 which came out were the mRNA vaccines. And they showed very high efficacy, 90%. The next one was the AstraZeneca, the Oxford vaccine, which then became Covishield in India. And then you had a number of inactivated. So China was producing a lot of inactivated vaccines, and Covaxin was an inactivated vaccine. It worked fine. I think it had around 75 to 80% efficacy, and it was safe. So, and at that time it was needed. All vaccines were actually needed at that time to protect people.
So thank you very much. I think all the panelists deserve a big round of applause. My thanks, of course, first to Anuradha for going through the pains, as you said, 9 months, and then delivering a beautiful book, which is very relevant. Thank you, Dr. Nalini, for conducting the proceedings so well. I am sure your open book examination, you passed with flying colors today. Passed. Yeah. And of course, to Soumya. I think I get to say the last word. So, my personal takeaway from the COVID epidemic was, as an administrator, we were in charge of the second wave in Pondicherry, jumping into hospitals, providing vaccines, providing for oxygen, etc., running through wards, things like that. But the revelation came when there was a curfew. We were going with sirens blazing, finding out who is not wearing a mask, and got hold of a poor chap on the road. and he said, I'll die of hunger rather than wear your mask and stay at home. So this is the aspect which now needs more of research, the social research which you talked of. I think we really need to find place in the playbook for such disasters, and how do we handle the economic and social fallout of such epidemics. On the medical side, we have a lot of people looking into a lot of things, but now we need social scientists, that interactive research which you talked about. I think that is what is something which is the need of the hour. We need to have scientists, we need to have social scientists, and also psychologists and even poets and writers to look into how to handle the after effects of such sudden events or extreme events that we are facing. Thank you very much for this illuminating discussion. All three of you made this discussion so lively. And I'm sure when we go through the book, we'll go through the details of what you have produced. Thank you very much. We hope to see you in CIC more often.